Good evening. Thank you so much for joining us. I'm Bob Golden, the Dean of the University of Wisconsin School of Medicine and Public Health. I also serve as the chair of the board of UW Health, the university's academic health system. In that role, I work closely with my partner, Dr. Alan Kaplan, who is the CEO of UW Health. Tonight is the second installment of our Wisconsin Medicine Livestream series. You know, there is a new era of medicine on the horizon. We hope that this series will provide you with an inside view into some of the very exciting developments that we anticipate going forward in the area of health and in healthcare. And we hope you give you a flavor of the remarkable ways in which the University of Wisconsin is a statewide, national, and even international leader in pushing forward the envelope in innovative advancements in health and healthcare delivery. In tonight's event, Reducing the Risks to Women's Health, we will explore how our dedicated physicians and innovative researchers who are never satisfied with the status quo are working so hard towards creative discoveries that will really improve the health and the well-being of women. To start us off, it's a pleasure to introduce Dr. Laurel Rice, who is the Ben Miller Peckham, MD, PhD, Distinguished Chair, and the chair of our university's Department of Obstetrics and Gynecology. In addition to her leadership roles within the School of Medicine and Public Health and within UW Health, Dr. Rice is also a practicing gynecologic oncologist. Welcome, Laurel.
Thank you, Bob. And I really appreciate your introduction. And thank you so much for joining us tonight. You could not find four more passionate individuals than those who will be presenting tonight around women's health. And complex women's health care is all about tackling problems that are unique to women and that disproportionately affect women. Our approach to complex women's health care is grounded in the Wisconsin idea. It is not enough that we give extraordinary clinical care, which we do. We strive to improve the lives of women and their families by embracing advocacy, policy development, research, outreach, all of it. And I can say confidently that we are recognized nationally and internationally on the cutting edge of improving the lives of women and families in Wisconsin and beyond. Complex women's health does indeed include all the complexities of caring for women as compared to men, but it's more than biological and temperamental complexity. Tonight, we will be highlighting programs that are focused on specific aspects of complex women's health, and we'll show you how the University of Wisconsin is leading. A prime example is the University of Wisconsin Health Breast Center. It is a multidisciplinary approach to caring for women who are at risk or have the most common malignancy affecting women in this country, and is led by Dr. Lee Wilkie. It includes surgery, medicine, genetics, radiation therapy, radiology, and Lee has just built a beautiful program, and we will be hearing from her tonight. Now, we're very fortunate at the University of Wisconsin to also have a multidisciplinary clinic around pelvic floor disorders. And you might be saying, what is a pelvic floor disorder? Well, tonight you're going to hear all about that from our own Heidi Brown. Our Women's Pelvic Wellness Clinic goes way beyond the boundaries of our clinic to reach women throughout the state of Wisconsin to improve their lives. The University of Wisconsin is one of only 25 academic institutions that have been awarded a grant from the CDC around prevention. We have a prevention center, and our center is focused on improving the lives of women, infants, and their families. It's a $3.7 million grant. And the mission of this center can't be overstated. The United States has the highest rate of maternal deaths when compared to 10 other Western countries. If you have a baby in the United States, you've got a twofold increased risk of dying compared to if you have that baby in France. And if you're Black and live in the United States, your risk of dying in a pregnancy-related event is 3 times higher than a white woman. This is a health disparity, and it is unacceptable. So what is the University of Wisconsin doing? Well, we were the first in the country to combine our School of Medicine with our School of Public Health. And to this day, we're only one of 2 institutions. And, we understand that a problem such as maternal death rate has to be addressed at a population health level. And we're leading the country. And using that lens of population health, we've recognized that 39% of the counties in Wisconsin don't have an obstetrician. And we also know that in rural Wisconsin, you have a 60% higher risk of dying in childbirth compared to non-rural areas of the state. We are the first in this country to develop a rural residency track in obstetrics and gynecology. We're on the cutting edge, and we've set the standard not only for the state, but for the country. It's the Wisconsin idea working at its very best. Advancing the healthcare in every arena, including men, women, it takes discovery, research. How do you improve healthcare? You have to research in all different areas of research, population health, basic science, clinical trials, etc. Research for women's health is underfunded and understudied. Between 2008 and 2018, the National Institutes of Health, which is the largest funding agency in this country, increased the amount of money they receive from the US government by 25%. There was a disproportionately low increase in the amount of money allotted to research focused on women's health. So as Dean Golden mentioned, I am a GYN oncologist. I just need to mention this is a really stark example of how this is hurting. In GYN oncology in the last decade, there's been a 90% reduction in enrollment in clinical trials with a 68% reduction in available trials, and this is terrifying. So ovarian cancer is the GYN malignancy that has got the highest mortality rate. And what this graph shows you that if a woman is diagnosed with advanced disease, which is the column to my right, the survival rate is dismal, and it really has not improved in the last 20 years. But at the University of Wisconsin, our own Dr. Lisa Barolette, who you'll be hearing from tonight, has been awarded a large grant from the NIH to focus on a drug that has real potential as a prevention strategy against ovarian cancer. I'm looking forward to hearing her talk. We are leading the way in women's health. There is no doubt about that. But we're not satisfied. We have dreams. We want to turn those dreams into reality. We know that we need to have more women in clinical trials. We know that we need to have more funding from the NIH around women's health research. Next paragraph. And we embrace that challenge. We are more than up to the challenge. And we know we've got to educate not only the NIH, but other funding agencies around the need for more funding and support. And with the incredible generous support of our donors, we're confident that we can continue to lead in this country and internationally in improving the lives of women, infants, and their families. Thank you. And Bob, I'll turn it back to you.
Thank you so much, Dr. Rice. Now it's a real pleasure to introduce Dr. Lee Wilkie. Dr. Wilkie is the director of the UW Health Breast Center, and she holds the Hendricks Chair in Breast Cancer Surgery Research in our Department of Surgery. Welcome, Lee.
Thanks, Dr. Golden, and thanks, Dr. Rice, for a wonderful introduction. What an honor and pleasure to be the director of our breast center, and I'm hoping tonight to talk to you more about breast cancer prevention and treatment. The world of human health is filled with conditions which are invisible to the unaided eye. A rather new invisible foe has occupied our world for the past 6 months. the coronavirus, and it affects about 13,000 individuals per month in the state of Wisconsin. A condition which has, however, existed since ancient times, breast cancer, is also in its earliest form invisible. And here in Wisconsin, it affects about 425 individuals per month. Unlike the coronavirus, however, the breast cancer is unique to the patient in whom it develops. Unless you're a twin, every breast cancer is different because your cancer cells form from your own cells, first at a microscopic level. In order to treat an invisible and always different foe, it takes a team of people. This team needs to be made up of individuals who come from different backgrounds and different expertise, so we can find the cancer before it becomes visible to the naked eye. Our team includes a wide variety of experts, but I will confess our frontline nurses are truly leading this charge every day to tackle the invisible foe. So what are we doing at UW Health to both prevent breast cancer and see it in its earliest and most invisible forms? Unfortunately, masks aren't a prevention strategy for breast cancer like they are for the SARS coronavirus, but we have many approaches for prevention, early detection, and treatment. So clinical trials are one of the most important mechanisms for testing new treatments to cancer prevention. The opportunity to evaluate new and exciting treatments versus the standard approaches is one way we ensure that new treatments don't replace the old tried and true ones until they are truly better. The UW Carbone Cancer Center is one of 4 cancer prevention consortium leaders in the United States. Breast cancer prevention is one of our main focuses, and there are 2 active and very interesting trials that patients at UW are participating in every week. One is an anti-estrogen or tamoxifen gel used for prevention of breast cancer in women who have dense breast tissue, which comprises about 50% of the population of women getting mammograms. By applying the gel to the breast versus taking it as an oral medication, it may act directly on the breast to prevent tumor growth when it is not yet visible on a mammogram. Another exciting trial is a trial looking at a 2-week study of a modified vitamin A. Vitamin A is a drug that it's been known at high doses to help stop cancer cells or slow them down. However, when given at that high dose, it really can cause some problems with your heart. So it's been modified so that it can be given to normal individuals and those with cancer. And we're testing it to determine whether it can help prevent cancer cells or slow them down. And we're doing this in a very short clinical trial, 2 weeks before surgery. The near ultimate mechanism for preventing breast cancer is to remove both breasts or prophylactic surgery, the primary reason for what is now called the Angelina Jolie operation. It's usually done in women who have a genetic mutation. The ones people know the best are BRCA1 and 2, which are changes in someone's DNA that they're born with that can lead to an eventual breast cancer and or other cancers. There are many more genetic abnormalities that can lead to cancers. As I said, BRCA1 and 2 are the ones that are most well known. Here at UW, we've built an amazing team of genetic counselors, breast surgeons, plastic surgeons, who can perform hidden scar surgeries, as well as surgeries that involve using someone's belly to make a breast cancer, to make a new breast, and try and prevent that woman from getting a new breast cancer. In addition to evaluating options for preventing breast cancer, the UW Health Breast team wants to find cancer at its earliest stages, when it's easier to treat and very invisible. In the spirit of the Wisconsin idea, the UW Health Breast Center, UW Carbone Cancer Center, as well as the Health Disparities Cancer Group and the CDC funded a Wisconsin Well Woman program and identified an individual to help us reach those individuals in what are called hotspots, or areas where breast cancer are more prevalent. Anna Karenna is helping us to increase screening and early treatment programs for these women found in the hotspots. And Anna works with our breast cancer specialists as well as experts from the CHDI to highlight the populations at greatest risk. As we support Wisconsinites in rural and underserved areas, the UW Health Breast Center radiology team has been on the forefront of developing legislation for informing all women in Wisconsin about the density associated and found on their mammograms. This legislation passed in 2018 and has helped inform women of their density so they can be active participants in whether they want additional screening approaches. One such approach about to come on the scene at UW for women with dense breasts will be the rapid breast MRI. Regular breast MRI is usually long and requires extended time in the tube. Now with a rapid MRI system, we can quickly screen women with dense breasts and provide another tool for early detection. In September, Dr. Mohammed Murtuza will be joining the precision medicine team at the UW Carbone Cancer Center. Precision medicine is techniques and approaches to personalize treatment to the patient and their unique invisible cancer. Mohammed has led as an incredible team of researchers over the past 5 years to identify a novel way to find the needle in the haystack or the cancer cell in a patient's blood or urine when there is very limited amount of cancer present. Dr. Murtuza will be working with the UW Health Breast Center to help unlock and find the invisible cancer cells in their earliest forms and proactively treat those patients who may have an early disease and evaluate response to novel treatments. The move to create and test a vaccine for COVID-19 as well as effective therapies has been fast and furious. For breast cancer and women cancers in general, we've heard from Laurel that research has sometimes been slow and steady. But here at UW, we're working to kick it into high gear, to focus on treatments for cancer that predominantly affect women. This includes a dizzying array of clinical trials and novel treatments. Each of these clinical trials is supported by a wide variety of foundations, consortiums, and the United States government, or NIH. To highlight just a few of these many clinical trials and novel therapies we are offering to patients, I believe the best way to understand the trials is to understand the phase of cancer they treat, from the early stages to later stage metastatic disease, which is spread. David Beebe, a world's leader in bioengineering and microfluidics, is evaluating how cancer cells, next slide, move from inside the duct at stage 0 to outside the duct, but he needs the valuable tissue we remove at surgery. Dr. Heather Newman, one of our remarkable surgeons, is leading the COMET study here at UW, which is evaluating not operating on stage 0 cancer and treating it with either anti-estrogen therapy or surgery. For women with early stage breast cancer, Dr. Carrie Wazinski is leading a trial evaluating a new SERD. No, that's not a bad word, but an estrogen degrader in association with Ibrance, which we see frequently on TV, to see if these drugs, which are not chemotherapy, could treat a cancer better than chemotherapy. And Dr. Burkhardt, who we heard from at the last medicine live stream, who leads our molecular tumor board, is evaluating how the plant Taxol, used as a common chemotherapy, actually works and when it doesn't work. Dr. Ruth O'Regan, our chair of hematology and oncology, is leading a trial of a death receptor, doesn't that sound cool, in association with a methionine-free diet to see if that can help kick a cancer into being treated better and removed from the system. Carrie Wazinski, again, one of our leading clinical trialists, is leading a Big 10 trial evaluating 2 novel drugs in triple-negative breast cancer. Each of these drugs have names that are nearly impossible to pronounce. At the heart of everything we do is our patients, as we try and find and treat invisible breast cancer foes. I'm thrilled to work with a fabulous breast cancer research advisory network that helps us understand which trials to move forward and which ones to redesign. I hope this quick tour of the UW Health Breast Center, for which I'm honored to be the director, has gotten you a taste of how we are finding and tackling our invisible foe, the breast cancer cell.
Wow, thanks a lot, Dr. Wilkie. That was wonderful. Next, we're going to hear from Dr. Heidi Brown, who is truly a remarkable rising star in the galaxy known as the School of Medicine and Public Health. Dr. Brown is an assistant professor of obstetrics and gynecology for now, and she also is board certified not only in obstetrics and gynecology, but also in female pelvic medicine and reconstructive surgery. Welcome, Heidi.
Thank you very much, Dean Golden. Good evening. I'm very excited to take the floor to share a little bit with you about taking the pelvic floor. And when I say the pelvic floor, I'm talking about the bowl of muscles and supportive tissues that support the bladder, rectum, uterus, and vagina. While most of us avoid talking about these taboo topics at work, it's what I do all day. And the reason why is because when the pelvic floor isn't working properly, it can have a dramatic negative impact on quality of life. As one patient describes, some people will say, I don't travel anymore. They don't say why, but they don't travel anymore. They don't dare go out anywhere, out to eat, out to a band concert, or whatever. They don't dare go out because they're. So, what are pelvic floor disorders? They're problems with the pelvic floor muscles and tissues that support our pelvic organs. Symptoms may include bladder or bowel leakage or incontinence, pelvic organ prolapse, where the vaginal or rectal walls relax outward, difficulty emptying the bladder or bowels, or even pelvic pain. And importantly, while we're focusing on women's health this evening, men can also experience pelvic floor disorders. I want to take a minute, since I'm the only one talking tonight who doesn't cure cancer, to acknowledge the fact that pelvic floor disorders are not cancer. You won't see local or national icons raising money or awareness about pelvic floor disorders. But the fact that pelvic floor disorders are not deadly the way cancer can be deadly does not mean they're not important. This is a quote from a 45-year-old patient with accidental bowel leakage. I feel alone and ashamed and unclean. The bathroom's my home. I feel older than I really am, and I worry about this problem getting worse. I always have to wonder if I stink or if anyone can tell that I'm dirty. Now, back to cancer for a moment. Breast cancer is terrifying and terrifyingly common. 1 in 8 women in the US will develop breast cancer, and those are women without a genetic predisposition. But 2 in 8 women, or 1 in 4 women, will develop a pelvic floor disorder before she's 45. And by the time we've gone through menopause, more than half of us will experience a pelvic floor disorder. So, though they aren't deadly, pelvic floor disorders are an incredibly important women's health issue. And here at the UW, we are moving forward to combat pelvic floor disorders. Just as Wisconsin was the first state to ratify the 19th Amendment giving women the right to vote in 1919, UW was the first healthcare system in Wisconsin to establish a multidisciplinary program for women with pelvic floor disorders. Our pelvic medicine clinic was immediately recognized as filling an unmet need for Wisconsin women, combining expertise in urology, urogynecology, and physical therapy to help women regain the ability to exercise with their kids and attend their grandchildren's baseball games, no longer worried about their pelvic symptoms stopping them. And over the past 6 years, our women's pelvic wellness program has become even more exceptional. We integrate diverse perspectives from our colleagues, not just in physical therapy, urology, and urogynecology, but also colorectal surgery and gastroenterology to help patients address all their pelvic symptoms at once. And this multidisciplinary approach enables us to deliver truly remarkable healthcare, whether a patient chooses surgery, medical, or behavioral therapy. We were one of only 10 sites across the country that participated in the landmark clinical trial of the Eclipse, an innovative vaginal device that treats accidental bowel leakage. As a result, Wisconsin women have had access to this device since the day it was approved by the FDA, but women across the country are not as fortunate. I've personally flown to Washington, D.C. twice to advocate for national coverage for the Eclipse, an example of how we at the UW are leading the charge to improve women's health across the nation as well as in our clinics. Unfortunately, most women with a pelvic floor disorder have never spoken with a healthcare provider about their symptoms and wait several years before seeking care if they seek care at all. So we decided to try to bring solutions to women outside the clinic, starting with senior centers, where many women already gather for meals, social support, and other health programs. We worked with the UW's Community Academic Aging Research Network, which supports partnerships between academic researchers and community stakeholders. We secured funding from the Wisconsin Partnership Program and the NIH to develop a program to bring incontinence solutions to women in senior centers. Working with 4 Wisconsin counties, we created Mind Over Matter Healthy Bowels, Healthy Bladder. This small group program, led by a community member who has been certified through a special 2-day training, helps women build skills and confidence to change behaviors to improve pelvic health. We then partnered with several additional communities to test the Mind Over Matter program in a randomized trial and found that the program had a tremendous impact. Women who completed Mind Over Matter had a 9-fold improvement in bladder leakage and a 4-fold improvement in bowel leakage without setting foot in a clinic. Because of our established partnership with the Wisconsin Institute for Healthy Aging, we were able to immediately start training Mind Over Matter program leaders throughout Wisconsin. And you can see how widespread it is already. In just over a year, over 300 women in over 20 counties have completed the Mind Over Matter program. While our progress thus far is an outstanding example of translating research into practice in record time, we won't be satisfied until every county in Wisconsin has Mind Over Matter program leaders. In fact, Mind Over Matter is in the process of becoming the first and only evidence-based small group program to improve incontinence in the country. California, New York, New Jersey, and Minnesota have already expressed interest in Mind Over Matter, and we plan to start national dissemination next year. But even when the in-person Mind Over Matter workshop is reaching women across the country, we won't be finished because we know that many women with incontinence need a program they can complete without leaving home. We've secured seed funding to develop an online version of Mind Over Matter and are currently seeking research funding to study its impact on symptoms. We are also working on innovation within the clinic. I wish I could share more details with you about one of our collaborations with the Department of Biomedical Engineering to develop a new device to improve urinary incontinence, but we've been advised that we can't talk about the ingenuity of our student team until our patent application has been processed. I want to close by saying that the future is bright. As long as women are bringing babies into this world, there is an urgent need for better strategies to prevent and cure pelvic floor disorders. And we at UW are up to the challenge. With the incredibly generous support of our donors and funders, we look forward to continuing to improve the lives and health of women in the coming decades. Thank you very much for your attention.
Thank you so much, Dr. Brown. That was wonderful. Our closing speaker for this evening is Dr. Lisa Barolette. Dr. Barolette is the Dr. Dolores Buckler Professor of Gynecologic Oncology at our School of Medicine and Public Health. Welcome, Lisa.
Thank you. Thanks for the introduction. It is humbling to follow Dr. Wilkie and Dr. Brown. I've been tasked with talking about discovery, a topic close to my heart. It's why we as scientists wake up in the morning, and it's certainly the only way to get me in front of a microphone with any enthusiasm. The University of Wisconsin has a rich history of approaching longstanding problems with creative solutions. Here are just a few examples of the novel discoveries that happened at our university. In 1923, Harry Steenbach and James Cockwell discovered that exposure to UV light increased vitamin D levels. This eventually led to the practice of enriching breakfast cereals with vitamin D, which effectively eliminated rickets in the United States within 20 years. Warfarin was discovered on campus after a farmer brought in a dead cow, from which an anticoagulant was isolated by Dr. Carl Paul Link. In 1966, the first kidney transplant was performed at UW-Madison. 7 years later, the first heart transplant was performed in the same building. More recently, WARF was assigned the patents for non-human primate and human embryonic stem cells. These are all tremendous landmark discoveries. Innovation on our campus knows no bounds and of course includes cancer research. This is relevant to our state's population, where we expect more than 35,000 individuals to be diagnosed with cancer this year and more than 11,000 people to die of some form of cancer. When you look, next slide, when you look at the types of cancer that are most common in Wisconsin, cancers that exclusively affect women, such as breast, uterine, and ovarian cancer, make up a disproportionate amount of cancer cases and cancer deaths. As Dr. Rice stated, research focused on female cancers is underfunded, and cancer treatment is only a piece of the puzzle when we think about reducing cancer's impact. Next slide. My dream is to never have to tell anyone's mother, daughter, or sister that they have cancer. Cancer prevention, as Dr. Wilkie stressed, is a huge priority at the Carbone Cancer Center. There are many ways to prevent to prevent cancer currently being studied right here on campus, such as creating vaccines that neutralize the infectivity of viruses like HPV. We are also studying estrogen receptor blockade to prevent uterine cancer, a cancer that often is fueled by excess estrogen. Another example is my lab's work, focused on altering cellular energy production to stop the very first changes that occur in a cancer cell. So now I get to tell you about my research, which is centered around a small molecule called atovaquone. Atovaquone is used widely across the globe to prevent malaria. Next slide. To understand how atovaquone might prevent cancer, we have to understand how normal cells become cancer cells. This is a complicated process, influenced by changes within the cell and by changes in the cell's environment. One of the first changes we see in cancer cells is how they create energy. Normal cells will use oxygen when it's available and make energy through a process called oxidative phosphorylation. Cancer cells are very nimble. However, they can switch between available resources quickly and have alternative energy production methods. We'd like to be able to stop cancer cells from adapting so easily to new situations. And atovaquone may be able to do this. Atovaquone blocks a critical step in this process, inhibiting oxidative phosphorylation. This forces a cancer cell to behave more normally and use oxygen stores when they are available. Blocking this pathway appears to have other downstream effects that prevent cancer. Next slide. When we expose ovarian cancer cells to atovaquone, the expression of a very important tumor suppressor protein called p53 increases. p53 prevents tumor progression by inducing apoptosis. Basically, it makes cells explode before they can undergo malignant progression. When p53 is active, rogue cancer cells can be eliminated before they cause trouble. Under certain circumstances, p53 can also come to the aid of a stress cell, functioning to protect the cell from damage and contributing to a survival response. You can see in this slide that the relationship between p53 and oxidative phosphorylation is complicated and relies on interactions with multiple proteins and pathways. Our laboratory is learning how to better understand these relationships and how to preserve them in cells that are predisposed to becoming cancerous. Next slide. Oh, that's good. Dr. Wilkie introduced the concept of the BRCA gene in the context of breast cancer, but women with BRCA mutations have very elevated lifetime risks of developing ovarian cancer too. Ovarian cancer is a challenging disease with a high mortality rate. Unfortunately, detecting it early is almost impossible. The current recommendation for most of these women with BRCA or similar mutations is to have their ovaries and fallopian tubes removed well before menopause. This means that BRCA-positive women are faced with impossible choices. They may not be able to complete their families. They may have to endure the health consequences of menopause at young ages, which can include sacrificing bone and cardiac health. We need better alternatives for these women. Our collaborators at the University of Michigan, led by a talented physician scientist named Kathy Cho, have developed a mouse model perfect for testing our hypothesis that atovaquone might delay or prevent the development of ovarian cancer. She has genetically engineered mice that have BRCA and other mutations built into their DNA, such that over time, we're talking months, they will develop an ovarian cancer that looks and acts like the human disease. We can learn not only about the timing of cancer development, but molecular changes that occur along the way. Because of atovaquone's excellent safety profile and the fact that it is an FDA-approved anti-malarial, we will be able to bring this work to human studies very soon. The generous funding we've received from the NIH includes a small clinical trial, during which we will sample the fallopian tubes of women several weeks prior to a planned ovarian and tubal removal. Between the fallopian tube sampling and the surgery, they will be exposed to safe doses of atovaquone. We can perform molecular testing before and after atovaquone exposure, giving us a unique window into the way atovaquone interacts with the cells inside the fallopian tubes. This study is not yet accruing patients, but we plan to have it open in 2021. I am fortunate to be surrounded by the absolute best colleagues, trainees, and mentors. Discovery does not happen in a vacuum. We need to rely on the strengths of our collaborators and the generosity of our patients who participate in clinical trials to move the needle, and we can't move it fast enough. I never talk about my research without acknowledging my closest collaborator, Dr. Manish Batankar. He's pictured to my right in the bottom photo, and Dr. Dee Beekler, whose generous support funded our pilot work. Thanks for your attention.
Well, thank you so much, Dr. Barolette. That was wonderful.
Thank you.
Well, as our presenters were sharing all this really exciting new developments, you've been sharing with us some pretty exciting questions. And for the first one, I'd like to pose this to Dr. Rice from her perspective as one of our leaders and one of the nation's leaders in women's health. Laurel, how can we continue to make these exciting programs and services available to all women without any roadblocks keeping them from benefiting from these new developments? Your thoughts about enhancing access?
Well, that is a very complicated question, but you hit the nail on the head. And a large part of this is education and informing women that they can actually get help for their accidental bowel leakage and can work on preventing cancer. And, you know, I think one of the biggest culprits with successfully disseminating all we're doing is the fragmented nature of healthcare in this country. There are many individuals with no health insurance that don't have access. Then we're dealing with racial bias. There's societal issues that really are a significant roadblock to dissemination. Now, having said that, this represents one of the reasons I'm just so proud to be working at the University of Wisconsin. Conquering that, and you've seen examples tonight. I mean, there's nothing better. Talk is cheap. Examples are what we're looking for. This is a state institution that embraces its responsibility for the whole state. And I could talk about this for hours. I mean, the way people show their commitment to this mission, not just for women, although tonight's about women, but it's the health of all Wisconsinites. I feel a deep pride with being here, and I am not from Wisconsin. I've been here 13 years. Dean Golden recruited me 13 years ago, and I am just a huge fan. Commitment to the mission and understanding and learning about the roadblocks that exist. I really continue to be shocked at my lack of knowledge about the roadblocks that face women in our state. But you know, I'm learning and I'm embracing what's available and what we can do as a team and people's commitment. So I'll stop there, Bob.
Thanks, that was excellent. I've got another question here I'd like to pose to Dr. Wilkie. Lee, you and some of the others also talked about how cancer care, medicine in general, is a team sport, okay? So we do have problems in Wisconsin, as Laurel pointed out, that there are, you know, dozens of counties that don't have an OB/GYN doctor practicing there. So if a woman is concerned that while taking a shower, she feels maybe she has a lump and she's nervous about it, what would be your advice as to the different pathways available to check out to see whether that's something that really needs attention? I guess what I'm saying is that if somebody has access to one member of the team, one type versus the other, does that matter? And what would you suggest to women who are living in some rural areas where it might be difficult to find specialists?
Bob, thank you for that question. It's such an important discussion point and consideration for how to reach all of the women in different parts of the state. I highlighted in one of the slides, quote unquote, some of the hot spots that exist where we see increased incidences of breast cancer, and it's multifactorial. Just like we work as a team, sometimes what we find out in the rural areas as causes for increases in cancer incidence and prevalence is due to several issues. Patients not having access to healthcare resources, patients being from rural areas and or areas that are exposed to potential carcinogens, though we don't know specifically which ones, as well as people being from families that may have genetic disorders that they're not yet aware of. And so when a patient feels an abnormality, we certainly want them to reach out to any of a number of different providers, primary care, OB/GYN if available, and or one of the members of a healthcare team. the exact reason that we worked with the Wisconsin Well Woman program, as well as CHDI, the Cancer Health Disparities Initiative, to hire Anna Karenna was to have her be out in the community in our Southwest region to reach those rural areas and other individuals to try and ensure that we can provide that access to individuals who have an abnormality. And certainly if they feel something, we want them to reach out and get a mammogram and get an evaluation. And then any member of our team would be happy to see them and evaluate them. So I hope that's helped answer your question.
Yeah, that's great. We have several more questions rolling in now, and people can keep them coming. This one is from Sue, who is a pharmacist in northern Wisconsin and would like to learn more about potential training in the community education program for pelvic floor health. How could someone, whether it's a pharmacist, a nurse, or some other health professional, get connected to the outreach and the training program about pelvic health?
Thank you so much, Sue, for that question. Actually, I was just kind of frantically typing into the chat bar. I want to respond to Sue S. in the chat bar. So we partner with the Wisconsin Institute for Healthy Aging, and you can go to their website, wihealthyaging.org. And then you can click on programs and click on Mind Over Matter. You can also, if you type in wihealthyaging.org/mind-over-matter, that'll get you there. And there's information about how to register for an upcoming training. And importantly, I'll just emphasize that one of the things that was really important to us with developing this program was that you don't need to have any healthcare expertise to deliver the program. That's one of the things that makes it first in the country, is that prior programs that have tried to do bladder health classes have all been delivered by somebody with healthcare expertise, but we wanted this to be something that could reach women throughout Wisconsin and other areas where there might not be anybody with healthcare expertise. And so people attend a 2-day training. Anybody can do it. All you have to do is be willing to learn. Thanks so much.
Thank you. Here's a question for Dr. Barolette. Dr. Rice mentioned that the diagnosis and treatment of ovarian cancer hasn't really changed much over the last 20 years. So in addition to your exciting prevention research, how do you predict the next 20 years will be? What do you see as the exciting, encouraging things in the crystal ball?
There have been some very encouraging developments. It just never moves as quickly as we want it to, right? I mean, when you have a patient in your office, you just want this problem solved immediately. The reality is, though, we've made some strides, and one of the best strides we've made is some targeted therapies for ovarian cancer that have been really effective in certain patients. Our BRCA patients, while it's no fun to have a BRCA mutation, we've learned that patients with those abnormalities and similar abnormalities, which focus on DNA repair, are very sensitive to a certain type of oral medication called a PARP inhibitor. And what PARP inhibitors do is act on part of that DNA repair pathway that's abnormal. So we really can give chemotherapy, an oral chemotherapy that's very specific to the actual pathways that are abnormal in that person's cancer. And this is happening throughout many, many different cancers. Dr. Mark Burkhart and his precision medicine and molecular tumor board is really trying to spread that across the state, so you can learn about the molecular changes in any patient's cancer by taking a simple biopsy or from tissue from surgery, and then actually try and find therapies that match that patient's specific molecular changes. So I do think there is some very exciting stuff coming our way.
Thank you. Here's another one, Laura, I'd like you to respond to. It really is shameful how underfunded women's health research is, and it's also very depressing that we are not seeing growth in clinical trials for women's health issues. From your perspective, what would it take to change that? What can we do to increase funding for women's health and to increase the participation in clinical trials?
Well, I'm pleased to have the question directed to me, because in the last 2 to 3 years, I've spent a significant amount of energy educating with other national organizers and organizations, our legislators on Capitol Hill, as well as individuals at the NIH, because part of this is calling it out. Because with the NIH being the largest funder, and they have all their data on the available for public consumption, but one of the problems has been defining women's health, because of course breast cancer has received tons of support, as well as it should. It's the most common cancer, but what that doesn't hit all the other diseases or problems that women face, but yet it's counted. So the short answer is engagement and advocacy. And I feel like the work that I've done in the last few years, I do feel that there's progress made. Francis Collins, who runs the NIH, the head of the Cancer Center, NICHD, we've gone to Capitol Hill, not so much during COVID, but I think we are making progress because it's a lack of awareness. Like so many things facing this country right now, including racial bias, it's that thing of becoming aware and learning. And I feel optimistic. I'm not depressed about this. I feel like the progress that's been made has been significant, and further engagement by everyone, not just physicians, demanding your legislators, our state legislators, to bring this forward on Capitol Hill. It's not hard to see. The data is compelling.
Excellent, thank you. Here's a question from Erin Bailey for Dr. Brown. How many diagnoses of pelvic disorders in women are pregnancy related, and are there other common causes beyond pregnancy for pelvic floor conditions?
Thank you so much for that question, Erin. Yes, pelvic floor disorders in women can be related to pregnancy. Pregnancy and particularly vaginal birth are risk factors for developing pelvic floor disorders. So is getting older, going through menopause, being overweight or obese, smoking cigarettes, and disorders that cause chronic straining like constipation or chronic cough. And there are certain inherited disorders that we're just starting to understand. We're just in our infancy of exploring genetic associations, but we do know that pelvic disorders run in families. I do want to emphasize, though, that not all pelvic floor disorders are related to pregnancy or delivery, and pelvic floor disorders can impact women who've never been pregnant or had a delivery.
Thank you. Here's a question for Dr. Wilkie. How do you identify people who are good candidates for invisible testing? Or to put it more simply, how do you know who to study?
Bob, Dean Golden, another great question. And I think it highlights the complexity of cancer and the development of cancer. As we know, it's different in everyone. And I think it's in its infancy and its investigation, but it's something that we're very excited, as I highlighted, in hiring Dr. Muhammad Murtuza, who is an expert in precision medicine, to figure out who needs to have potentially a blood test that helps us understand if they have a cancer, how we're responding to it, and if they are at high risk for cancer, if they might be developing it before we can see it on an X-ray or on a physical exam. So we're very excited about these opportunities for research to test both blood and urine, looking for what's called cell-free DNA or circulating tumor cells. And I think it's a very important research area that we're going to be investigating in great detail in our high-risk individuals, people who've had a biopsy that shows atypia, so we can help understand whether they're going to potentially be at risk for cancer in the future. And I think as we move this research forward, we'll be reaching out to individuals around the state who might be interested in clinical trials and or studies such as these. And we greatly appreciate people being interested in these approaches.
Thanks, Lee. Here's an interesting question for Dr. Barolette. How in the world did a malaria drug become identified as a potential way of preventing cancer?
Yes, like most discovery, it was a series of coincidences. But Dr. Manish Patankar, who I mentioned at the end of my talk, has been interested in molecular metabolism and cellular energy production for a long time. And he's looked at a number of agents for cancer treatment. So there's other drugs in this class that are more potent. That have been trialed. One of them is called YM155, and you'll see that in some prostate cancer trials if you do some digging. So he was interested in those compounds, but was frustrated with atovaquone because he said it wasn't potent enough. And he wasn't as interested in studying it because it wasn't killing cancer cells in the lab the same way some of the other agents were. But I thought, wow, this is a really safe medication, and you can take it when you're pregnant. I mean, people have been on it for years in parts of the world where malaria is endemic. It's hard to find good drug candidates for prevention because for them to work, you have to be on them for quite a while. So I said, hey, let me take this to the next step and let's see where we can go from this. It was just luck, honestly.
Well, I suspect very well-educated luck. That's a great story. Here's a question maybe for you, Laurel. Can you tell us how telemedicine or other approaches are being utilized by UW Health to increase communication and outreach to women in rural Wisconsin?
Well, this is a really important topic that's been crystallized with COVID to some extent, but even pre-COVID, for pregnant women, hypertension is very much a problem that can and does contribute to maternal death rates. And UW has a novel program with at-home monitoring for hypertension that involves telehealth visits. And we have significantly improved the management of postpartum hypertension in Dane County and the rest of the state. But speaking direct, so I think there's just tremendous potential to facilitate care in rural Wisconsin. I do think one thing that's important is access and ability to have broadband access. UW's been nimble and able to offer video and telephone visits thanks to COVID. We made a huge effort, and that has been effective. And I'm sure once COVID comes to an end, God willing soon, that telehealth is going to stay in place for a significant part of the healthcare we deliver, certainly to rural Wisconsin.
Thanks. Other thoughts? Lee, do you have any ideas about that?
Yeah, I think the neatest thing that's happened, one of very few things with COVID, is that we've realized the depth and ability to use telehealth. We've certainly started doing a second opinion program in our breast center for individuals that can't get to us originally because we were under quarantine. And now because we realize we can do a second opinion with 3 doctors with 1 patient who's in their own home and with their family and able to feel comfortable about a discussion around options for cancer, even though they may not be able to get to Madison right away. And we can offer options for how to treat them. So telemedicine and telehealth has really blossomed as an opportunity and something we're looking into as options for both clinical trials and treatment.
Thanks. Here's a fairly specific question for Heidi. Are there options available for women who have had failure to adequately respond to bladder lifts or to physical therapy? What would you recommend in those kinds of situations in general?
I would say absolutely yes, 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 there are options available. Some of my early work was around barriers to help seeking for pelvic floor disorders. And one of the things that we learned was that a lot of times people have asked a physician, a well-meaning physician who said, oh, well, there's really nothing else that can be done. Oh no, there are so many things that can be done. We have devices like the one that I showed, the Eclipse bowel control insert. We have lots of devices that we can use. We also have in-office procedures where we can stimulate nerves to improve symptoms. And there are new surgical approaches that we're exploring always. We're also doing some stem cell research collaboration. So yes, yes, there are still options if you failed a bladder lift and pelvic floor PT. Don't throw in the towel. Come and check us out.
Great. Sounds like lots of options and lots of hope into the future. Here's one that several of you could take on, but let's start with Lisa. Could cellular therapies someday alter gene mutations such as the BRCA gene to eliminate the translation of its devastating effects?
I think so. I think gene therapy is such an interesting concept, and thankfully that work is happening here as well. We have some incredible experts doing groundbreaking work in how you could use stem cells or gene therapy to, I don't want to say better DNA, but replace the faulty parts of an individual's DNA. I think we're a ways off. As you may know, there's been some very serious side effects from gene therapy too. It's not a slam dunk. It is really, really complicated to get it right, and it's very imperative that it be done perfectly. But I do think that's one of the next waves of treatments coming our way.
Thanks. Here's one for Dr. Wilkie. The recommended guidelines for the age and the frequency of mammograms, it's sort of like, the weather in Wisconsin. It changes very, very rapidly. And over the last few years, there's been a lot of confusion, I think, for physicians as well as the general public as to what are the best practices. Any thoughts about that? And in general, what do you see as the appropriate role of mammography in your work in trying to study ways to prevent breast cancer?
Dean Golden, that's an excellent question and one of the hardest to answer. I think mammography and its timing and how often is one of the most complex questions we answer on a routine basis in the breast center. We find that we really like to take a middle ground between all the different societies and groups who make these recommendations, because there is clear evidence that mammography saves lives and reduces, in addition to mortality, but also morbidity. That if we find something earlier, we are more likely to do less therapy and less interventions if we can find it smaller and less aggressive and less spreading. So I do encourage women to think about getting a mammogram starting around age 40. And for some of our African-American women, we may be starting to think about doing it earlier because it shows up earlier in that group of individuals. So there's a lot of research around this. There's a lot of interest in making sure that we get it right for each individual, and know that not everybody should follow the same regimen. And we're hoping to use mammography and breast density to help define who should be getting it when and how often. So I skirted around your question a little bit, but tried to emphasize that it may need to be personalized.
Excellent, thank you. Here's one for you, Heidi. How does a device like the one you showed for bowel health get developed? Do you collaborate with other departments, other schools? What kind of village does it take to raise up that type of new innovative treatment?
Well, interestingly, that device came out of a very similar collaboration to the one that I gave the little teaser about, like I can't share the details, that the Eclipse discovery came through a collaboration between physicians and biomedical engineers at Stanford. And we have a novel program here at UW where physicians can submit an idea for an invention that we'd like to see happen. And then a team of biomedical engineering students works on the idea. And we actually have this awesome device in the pipeline right now. So biomedical engineers, physicians, and then we also loop in expertise from people in marketing, people who evaluate the business proposition and what does it take to really make this have a splash and really reach the people who it needs to reach to be effective. And so it really does take a village. And I can't emphasize enough how fortunate I feel to be at UW, where there are so many opportunities for true collaboration to really make things possible that would not be possible without these fruitful multidisciplinary collaborations.
Thanks, Heidi. Okay, we're down to one last question, and I think this will have to be a quick response. Why don't we finish where we started with you, Dr. Rice? What makes you wildly optimistic about the future of women's health?
I am optimistic, and I feel that the work that's been done, a lot of it here at the University of Wisconsin, but throughout the United States, to raise the bar is finally getting the attention it deserves. It's just reached the critical mass. The commitment's there. The understanding of the depth and breadth of the problem is real. And I can speak to our community here at the University of Wisconsin, and Heidi and others have highlighted this, that it's the collaborative spirit, it really is the Wisconsin idea that makes me feel even more optimistic because of where we all work. This is a tremendous community, and I feel privileged to come to work here every day.
Well, I want to thank all four of you for this wonderful panel. And I also want to thank the audience, all of you out there, for joining us this evening. I hope you enjoyed this as much as I did, and I hope you have left with a sense of all the exciting developments taking place here at the University of Wisconsin School of Medicine and Public Health, and all the ways in which it can have a major impact for women across our state and across our nation. I hope you'll join us for the additional programs that we have in our series, including 2 weeks from now. We're going to have a wonderful panel talking about our strategy to end Alzheimer's disease. So please tune in for that one. It'll be another example of the exciting things that are taking place right here at UW Medicine that are really going to change health and change our state and change the world. So we're going to wrap up for tonight. Thank you so much for joining us. Please take care of yourselves, stay well, and stay healthy. Good night.